So I want to just thank you guys. So far, everyone has been really engaged and asking great questions. I think one of the tough parts about putting together a symposium like this is just knowing that everybody needs individual advising. So during the break, I talked to someone who was an international medical grad. We know that some of you are osteopathic. We know that some of you are military. And so we try to put together a program that's kind of all-encompassing, but in some ways that's a little bit difficult. But I think the lunch will be a good opportunity for you to find some advisors from those different areas. And also, if you don't get what you need here, you can email one of us and we'll put you into contact with somebody. So Sharon is here and she's going to talk about the SLOE and hopefully answer some of your questions.
Absolutely. It's really great to be here. My name is Sharon Bord. I am coming from the Johns Hopkins University School of Medicine. You are probably the biggest audience I'm going to be speaking to during my time here at SAEM, as some of the rooms have tiny attendance. So this is really, really exciting. I'll also, in regards to what Dr. Kaman was saying, put in a plug on the CORD website. There is an Ask EM section, which is the Advising Student Council in Emergency Medicine. And in there are kind of specific guides for people who are DOs, for military matches. So it's a really good resource. There's lots of links there. Obviously, there are some special circumstances, but it may not be a bad place for you to start if you have some questions about kind of more specific things. So I am going to be talking about the SLOE. Who knows what the SLOE is? Most people? All right. I am a big SLOE nerd. This is a topic that is very near and dear to my heart and something that I have put a lot of thought and effort into. And we'll talk about that as the talk goes on. You know, Nick and Gannon assigned me this lecture, and they actually named it Slow Your Roll. So I was like, well, what things roll? And then when you go and you make PowerPoint slides now, they have all those fancy design ideas and stuff. So one thing that came up was sushi. We're going to continue a sushi theme throughout. We also could have done a skateboarding theme. So we'll have a little fun with the SLOE letter, as much fun as the SLOE can be. So what will we be discussing? So we'll talk a little bit about what the SLOE is, even though many of you are familiar with it. We'll give a little bit of history. We'll talk about how you get a SLOE letter and why it's important for your application, and a little bit about what your application can look like in regards to how many SLOEs are there and and kind of what your grouping of letters can look like. And there's a large variety, and that's something that students are always concerned about. And then, last but not least, we'll talk about changes to the SLOE and what that means for all of you. This year, there will be a new SLOE coming out, something, again, that I've worked quite a bit on. And we're really excited about some of the changes, and we're hopeful that it will be most reflective of your performance in medical school and on your rotations. So we think that there will be good, positive changes. Now, history. We're not going to talk a lot about history here. But the SLOE originally was called the SLORE, and Dr. Kaman probably remembers those times, and if there's any other faculty here. And originally it was called the SLORE, and that stood for Standardized Letter of Recommendation. And that was way back in 1997. We were the very first specialty to have a standardized letter for our students applying into emergency medicine. In 2014, this was changed to the SLOE, which stands for Standardized Letter of Evaluation. So we changed that word from recommendation to evaluation because we wanted to make sure that we were being honest as we were sending people off into residency programs about their skills in emergency medicine, about how they compared to their peers. And then in 2016, we got very technologically savvy, and we developed the e-SLOE, which stands for electronic SLOE. And one of the benefits of that has been that we can track data over the years. So we can see how different people kind of rank over the years, how different institutions have been using this letter of evaluation. And then we can put the second point. In 2022, we are coming out with the e-SLOE 2.0, which will be with the most recent updates. When the SLOE was first developed, or the SLORE was first developed, the goal was to create a standardized letter that would be concise and that would be discerning and discriminating of the students who were applying. Now, all of you are going into emergency medicine, and you know that some of us, or many of us, potentially have a limited attention span, right? So reading a letter that is nice and concise and standard, and we know it's going to be in the same format for every single one of our students who are applying, was really, really, really helpful to us, for the readers of those letters, for the writers of those letters, to be able to have a really just standard format. Now, do you need a SLOE? This is a funny question, right? Because all of you are like, yes, we definitely need a SLOE. And there's a lot of pressure that's put on the SLOE, and there's good reason for that. This is one of the most important aspects of your application when program directors were surveyed. They said that letters of recommendation in the specialty were important. 97% of people said that. It probably, if you ask now, would be 100% of people would say yes. We want to make sure that everyone has this standardized letter on their application. And the average rating of importance was 4.8, compared with a lot of the other things. And again, this is slightly old data, and some of this has changed. The USMLE Step 1 is up here as also a very highly rated thing on the application. And as all of you know, the USMLE Step 1 is going to a pass-fail exam. So obviously that could potentially change some of this. I think all of us in the education community are saying that that change of the USMLE Step 1 to pass-fail will then increasingly put more weight on your standardized letters. Now, the other thing that I love is that the emergency medicine SLOE is really a trendsetter. All these different specialties over the last about 5 years, so they've been a little slow to catch on, in all honesty, right? We've been doing this since 1997, but all of these specialties have now developed a standardized letter. Dermatology, orthopedics, internal medicine, OBGYN. I think there's a few others out there. Internal medicine is one of the most recent ones. I think ENT has a standardized letter. And all of these programs actually look to the SLOE for inspiration for their letter, for formatting help with their letter. They all really have utilized the research that we've done on our letter and have used that to adapt to their specialties and develop their letters. There's actually a ton of great research and interesting stuff about all of these letters. My favorite is the orthopedic research, where they say all of our students really did amazing on our SLOE letters. They all had excellent ratings. And they say it could just be that all of our students who are applying into orthopedics are amazing and excellent. And really, we know that there's a big problem in left shifting of evaluations and letters. So I always get a little bit of a giggle out of that when like the dermatology and the orthopedic people say that stuff about why their letter is very left shifted. Now, how do you get a SLOE? Generally from a home emergency medicine rotation. I know some of you don't have a home emergency medicine rotation. And then your SLOEs will mainly be coming from away emergency medicine rotations. It's oftentimes the expectation when you go and you do an away rotation that you'll get a SLOE from that kind of experience in rotation. I always tell my students who go and do away rotations, they're always like, well, do I have to ask, and all this other stuff. And I always say that generally it is the expectation that that person, when you go and you do that away rotation, will write you a SLOE. It doesn't hurt to kind of verify and ask. It's very helpful to us as kind of clerkship directors and student educators if you don't need a letter. So let's say it's your third rotation, or you're doing it later in the interview season. If you don't need a letter, that's helpful for us to know. Definitely tell us that. But these are generally how you're going to be getting your SLOE letters for your application. Now there's an e-SLOE, but are there others? There are, in fact, other kinds of SLOE letters. We'll call the e-SLOE the California roll. So this is our standard, reliable letter, right? I mean, when in doubt, you're like kind of hungry for lunch, and you go there and you're like, okay, we'll go ahead and we'll get the California roll, right? This is the thing that you're always going to want to get. It's always going to be there for you. There's a subspecialty SLOE. And these, I call them, I was like, we'll call them a spicy tuna roll because they're from rotations that are full of spice and are kind of exciting. So your ultrasound rotation, your PZM, your tox rotation. The subspecialty SLOE letters will very closely mirror what that e-SLOE letter looks like, but will be based on your experience in more of that subspecialty time. There are non-residency program SLOEs. So the SLOE originally was designed to be used by residency programs. And there are some questions on there that ask, where will this student be on your rank list, right? So if you don't have a residency program, it's hard to say that. That letter looks similar. What's that? I call it the salmon avocado roll. So it's, also a good standard, right? It's a little bit different. But that letter, again, will very closely mirror that e-SLOE. And then the o-SLOE is the off-service SLOE letter. This letter was developed right at the start of COVID when we were saying like, our students may not necessarily be able to go and do away rotations. How can we create a standardized letter that will be filled out and completed by people from off-service rotations? So if you rotate on the internal medicine service, can that person then fill out a more standardized letter? Narrative letters, if you've ever read one or written one, are generally very effusive. You are the best thing ever. This was one of the best students I've ever worked with in a million years. And as great as those letters are, sometimes they don't give us the most information about you when you're applying. Now, the o-SLOE was met with kind of mixed reviews. We're keeping it around for now, but there's a possibility it may be taken off our sushi menu in the coming years. But we're gonna have it out there for the next couple of years and kind of see if it's utilized. One of the things that I think is potentially good and can increase utilization is the fact that so many other specialties are now using standardized letters. The format is a little bit more familiar to them. So on your application, this is a question, again, that students ask very, very frequently. What can it look like? So you can have 2 e-SLOEs, one from a home rotation, one from an away, or potentially, if you don't have a home rotation, 2 away rotation e-SLOEs. You can also have 2 other types of SLOEs as your letters. So for example, if you do a rotation in toxicology, if you do a rotation in PZM, you can have those other letters there. Or you can also have 2 other letters as well. So a narrative letter or a letter from a research mentor or an o-SLOE could potentially be within those letters. There are some special circumstances where you may have more than 2 e-SLOEs. So there are some students, the current consensus recommendation is that you have 2 EM rotations, but there are some students who potentially have exceptions to that rule who may benefit from going and doing a 3rd EM rotation. If that is your situation, I don't know if someone else is talking about away rotations. Yes?
Yeah.
Okay, perfect. I won't go too much into it. Now, we are going to talk briefly about changes to the SLOE. And this is really hot off the presses stuff. We are working on programming the e-SLOE into our new system. And we are excited about some upcoming changes. In April 2020, the SLOE committee reconvened. So it had been kind of not really active for a number of years because the e-SLOE was there. It was kind of chugging along. COVID happened, and the request from CORD and CDEM, SAEM was to make the SLOE come up with something that could stand in. That was the o-SLOE. And then also over the next year or two to help kind of bring the e-SLOE up to speed. This was also in light of the USMLE going to pass-fail. Like I mentioned, many people think that that will lead to increased stress on the SLOE, and then other kind of COVID changes that occurred during that time period. We have great representation on our SLOE committee. We have representation from CORD, CDEM, EMRA. I am co-chair of that committee with Dr. Hegarty, who is a cord member. So we have really representation from program directors, from advisors, student advisors, and then we also have learner perspectives with our EMER member. We also sent out a big survey to cord and CDEM and kind of got people's feelings on the current e-SLOE, what they felt about it, what they felt they wanted changed. And we created the o-SLOE from this. And then we also are coming up with a new version of the e-SLOE that will be released in June of 2022. So your letters of recommendation, if you've already done a rotation, holds off on having them write that letter. And if they've already done so, so be it. But most people have not started writing letters yet, and we will have this out hopefully in the next few weeks. Now, why did we want to change the SLOE? What are the challenges with it, right? I was just saying how great it is, how wonderful it is, how much we love it and how much we value it. Well, one of the big issues is that it's very shifted to the left. I was joking around about ortho and derm being very shifted to the left and everyone being very great, right? But we see the same phenomenon in emergency medicine. The other issue, for those of you who have looked at the SLOE, is that we have people in like these 3/4 buckets is kind of what they want us to put people in, and divide people into thirds. So this is a top 10% student, a top third student, a middle third student, a lower third student. And one thing that we always kind of scratched our heads about are, do students really fit into these 3 buckets, right? We know that a majority of you are going to be great residents, right? So is there really a need for these kind of top third, middle third, lower third? Also on the SLOE, there's no competency-based assessment. The EPAs and the AMC are very much pushing for competency-based assessment and more competency-based assessment for our medical students. And then, is there any missing info that would be helpful for us to gather or for us to know from about students on the SLOE? So how will it look different? There's some logistical differences. So there's a spot on there where we say, like, is this a home student or a visiting student? There's a spot that asks, or a question that asks, what is this evaluation based on? So is this evaluation just based on evaluations? Is this based on feedback, verbal feedback from the residents, verbal feedback from the faculty? Is this based on any feedback? I know that Dr. Sunger was just talking about being nice to the coordinator. Is it based on feedback from your coordinator, from your nursing staff? So what are we basing the evaluation on? There will be a question about exam scores. So if you have a test, either one of the SAEM tests or one of the NBMEs, what was your score on that exam, and what is the average exam score at that site? There's going to be a criterion and competency-based section, which looks similar to the NCAT, which is the National Clinical Assessment Tool, which is an EM-specific evaluation tool that's used at a certain, at some medical schools. And in there we will ask about the history and physical exam, differential diagnosis skills, your ability to generate a plan, procedures, your ability to manage emergent issues that arise for your patients. And that will be very competency-based. So it will ask if you are entrustable, pre-entrustable, in those categories. So more based on the EPAs. The other part that's going to look a little bit different is on the evaluation part, where we're going to talk about more kind of soft skills. So compassion, sensitivity, respect towards patients, ability to incorporate feedback. And here we're going to have a 1 to 5 Likert scale. Again, it's going to look different. We know that many people are going to fall in this 3 zone, right? And that's okay. That means you're going to be a great resident, right? So we're changing the way that we're kind of thinking about and evaluating our students. We want this to look like a bell curve for different programs. We want this to be that you have the most people kind of there in the middle, and then there's going to be outliers in kind of on the bottom and on the top. The other question that looks a little bit different is our overall evaluation of you as a student. And this is a little bit like kind of that bucket question, but we're changing kind of how we're evaluating you. So it's not a top 10%, top third, middle third, lower third. We're saying, how much guidance do you think the student will need as they enter into residency? Will they need minimal guidance, standard guidance, moderate guidance, or the most amount of guidance. And again, we anticipate that most people will fall into the standard guidance category, and that's okay. That's where we want people, right? Some people may be a little bit lower, some people may be a little bit higher. Looking forward, we're really hopeful and excited about these changes to the SLOE. We think that it will be helpful for programs and will help best differentiate students. And also, we're hopeful that this letter may be able to highlight strength and growth areas. We're also hopeful that we're moving a little bit to competency-based information, which is in line with what the AAMC is asking for medical schools. And we're keeping the e-SLOE around for now, but that may change. I'll take a few minutes, I think, for questions. So I don't know if we can necessarily speak to how much everything is weighted. I think that that's very different program to program, right? So what might happen in Hopkins may happen differently at Denver. So I don't know if we can necessarily say that. Is there a benefit to having it? I think if you go and you do that experience, right, an ultrasound experience, a tox experience, PZM, or other, there's a handful of other things out there. I think that there is a benefit to having it on your application. I think one thing is if you go and you do that, so let's say you do ultrasound and you're very interested in ultrasound, right? That speaks to your interest in a potential sort of niche in the field of emergency medicine.
Yeah, if I could just reflect, and I don't know if our program's different, but there's a select group of people that write the SLOE, the department SLOE that you get from the clerkship, and there are a lot of really high-quality faculty teaching other things, you know, our ultrasound clerkship, our disaster medicine elective, that aren't on that SLOE. And in years past, we would just write a different SLOE. But now I think we've pivoted to a subspecialty SLOE, and that's kind of the one that I've been writing a lot of. And I really hope there's still a lot of value to those because I do a lot of the advising, you know, but I'm not, because of the people that are on the department SLOE, I'm actually not on that one. I also think it gives the students another chance to have an extra letter from their home institution. And, you know, knowing that it falls a tier below the actual SLOE, that's kind of our situation, and there's probably other places that are like that, I would suspect.
So for people who have already done home rotation or on home rotation like this month, next month, will there be two different SLOEs evaluated this cycle, like the old one and then 2.0?
Yeah, I think that for the most part, we are kind of getting word out to our education community to hold off on writing letters until the new e-SLOE is released. The other thing that's important to know, and I think that's the reason that a lot of people don't write letters till later in the season, is that there is still some comparator to your peers that are applying with you during that application cycle. And at this point in the application cycle and in the rotation cycle, all of that information is probably not there yet. So I think that many people, even if you've already completed your rotation, don't always fill out the complete letter. I also believe, although I'm not 100% certain on this, that the regular e-SLOE is offline right now. So that kind of limits people's ability to fill it out at this moment.
If you're going to have a subspecialty SLOE, is that going to be in addition to your own AI?
Yes. So that can be in addition to that. Yes.
So it's okay to do that.
Yes. Absolutely.
If we do a subspecialty QA rotation, is it you know, to your point earlier about having too many SLOEs, like we're going to trend towards average, would it be a red flag if we didn't have a subspecialty SLOE in that rotation? Should we ask for one if we do one?
I'm not sure. I think that's a very personalized question.
I think if you do one, you should ask for one. Again, like we're not as we probably won't know that you did a 2-week ultrasound rotation and didn't get a subspecialty SLOE, but I think because the subspecialty SLOE is distinct from the e-SLOE, it's rare that it's going to hurt you. And it's typically speaking, I think it augments your application in the sense that it, again, is Dr. Bord said, it shows your commitment or interest in a subspecialty of emergency medicine. And so those SLOEs tend to be very positive because they're focused on a specific subspecialty over a shorter amount of time with less comparators.
Like, I think it depends on what, like, this is a very good ask for your advisor, because if it's like you wouldn't really have a fourth letter otherwise, and that's gonna be your fourth letter, cool, it's gonna be an add-on. If it's, you actually did some research and you have this opportunity for like a research mentor to be like, I worked with a student for 6 months and they were like amazing and they got to all their deadlines, versus like, yeah, in 2 weeks had ultrasound, we did the scans, cool, right? Like, I think that that's like just a very personal kind of thing.
And one more, sorry, one more. Should it be our goal to have 4 letters? Like the 2 primaries and 2 others?
So I think 3 or 4 letters are generally what students have. I always tell my students it's better to have high quality letters than to have fluff letters, right? So if you have 2 SLOEs and then a great letter from someone who you worked with on a critical care rotation, medicine, or research mentor, I think that's fine. I think it's quality over quantity is always my thought.
And just the last, you can always collect letters, right? So you go do a subspecialty and get a letter, and then it's up to you whether or not you want to post it, and that's in discussion with your advisor for all these points that are being mentioned. But it's much harder to say in October, man, I really wish I had that subspecialty SLOE from my June ultrasound rotation and collect that letter.
Yeah.
If we're not going to be able to do like a significant off-service rotation between now and Christmas time, is it okay to get no SLOE from an M3 rotation, or do people not do that?
Yeah, again, I think it's very much a quality over quantity situation. So if you worked with a faculty member and they really got to know you very well and understand your clinical strengths and weaknesses, I think that's absolutely fine. Yeah.
So I'm being an international medical graduate, so I'm doing the research in the institute. Would it be possible if I get like that research slow, because I'm graduated, so I don't have really chance to get a slow. Would it be possible if I get like the research slow and doing the rotation with the subspecialty right now? What is the advantage and disadvantage to getting the research slow instead of like getting the like subspecialty?
Yeah, so you could have like a subspecialty SLOE in the area of research. The issue is that the SLOE is meant for clinical experiences, right? So it's asking how you interact with patients, how you generate a differential diagnosis. So it's not really geared necessarily towards research experiences. Does that sort of answer your question? Yeah.
It's like I'm doing the rotation, I'm getting a clinical experience too.
Got it.
Research. So that's what I'm asking you. Like I'm rotating all the area toxicology, trauma, and all the subspecialties for EM.
Yeah.
So that's what I'm asking. Like, which is the most important to get that add-on from each area?
The clinical experience one is the most important one to get. Yeah. I think maybe one more question. I saw one more hand raised. Ooh.
When did you say the competency-based evaluation was
The new letter should be out in June. Yeah. Is our hope, providing no hiccups along the road. It's being programmed right now. That's a really great question. I know a lot of, it's always amazing to me how quickly, like June to October 1st goes, right? I'm always like, how is it October already? Partially because it's the summer and partially because all of you are being asked to squeeze so much rotation and time into like this limited period of time, and your clinical schedule may not line up with your away rotation clinical schedule. So sometimes you may not be able to go do an away rotation until like mid-August till mid-September, right? And when that rotation ends, is the expectation, are you asking too much of your, the people who run the rotation to turn around and get that letter in, in 1 or 2 weeks' time? I always tell students who are rotating them, like, my goal is to get that letter in for you as quickly as I possibly can. And my goal is always for that, I think it's like this year, October 1st, I think it's like a Sunday. So I think it's the September 29th or something, that applications open, ERS opens for programs to start reviewing. My goal is always to have letters in by then, providing you finish your rotation, in the last 1 to 2 weeks. Sometimes it's hard. Sometimes it's a significant time crunch. the most important thing is that you have one SLOE letter on your application when that ERS opens, and we anticipate that there are going to be people who are doing those slightly later rotations, that second e-SLOE may trickle in like mid-October, and that's okay. Many programs will review with just one SLOE, and I think that program directors are very aware of this time crunch and are gracious about reviewing with one SLOE and knowing that the other one is probably close behind. Do you agree? Yeah.
Yeah, I mean, I would just add the LCME requires clerkships to have grades in within 6 weeks. So sometimes I tell students, I mean, that's kind of the border, because they need your grade to write the SLOE. So I don't think it ever gets that long, and we are always trying to be cognizant of application deadlines, but if you keep 6 weeks as the limit of when that letter can come in, that might help you time your rotations a little bit. All right.
All right. Thank you, guys.